in 96, and then shortly afterwards came as a coordinator in 97. So of course at that time it was still the National Confidential Inquiry into Perioperative Death, and we debated long and hard. Chris Hargrave, Chief Executive, is in the former Chief Executive, is in the office, in the audience, about how or whether we should change the name and the logo completely, or whether we should subtly change the words but keep the logo. And in the end, we decided to pretty well keep the branding logo because we thought it was worth keeping. It was, of course, something, as I've said, that was very new for its time, and even after the early years of CPOD, we continued to face numerous challenges, not least the funding, but also resistance from various quarters of the profession. And it's perhaps just worth going back to 1956, when the original 1,000 deaths was reported on by the anaesthetists. The surgeons, of course, didn't want to have anything to do with it at that time, and it was only when there was a republish in 1982 that they started to feel, I think, that they had to get involved. But up until 1982, surgeons hadn't really felt it was a good idea to be looking at what had gone on and trying to learn from it. But it was the endeavours of Messrs. Lunn and Devlin that actually brought anaesthetists and surgeons together. And for me, it's really a little bit like that, the confessional. It was that safe space that allowed individuals to say things about their own practice that they perhaps wouldn't have felt they could have said before. Certainly in the early days, when we used to look at the surgical and anaesthetic questionnaires in parallel, it was often quite striking that the account of events was very different indeed from the surgeon and the anaesthetist. I mean, it was not uncommon, for example, for the surgeon to say, yet again, case delayed for a long time while anaesthetists asked for totally irrelevant blood tests to be done. And you get the one from the anaesthetist saying, yet again, surgeon wants to rush in without doing proper preparation and resuscitating the patient. So you got two completely conflicting views of the same thing, which was always fascinating. I think it's pretty doubtful if we started off again if we could actually do what Devlin and Lunn did today. It's pretty tough. And as I said earlier, the success of this endeavour really does rely on the continuing trust of the professions, that wider profession now, not just surgeons and anaesthetists, but the whole healthcare team and the other professions as well. But some of the things that I think give it credibility are the things that have become embedded in our everyday language. So the NCPOD classification of surgical interventions, for example, the NCPOD classification of admissions, have lasted and endeavoured over time. So, as you can see, as Nigel showed you, I mean, we've transited gradually from some fairly simple graphics across to much more complicated ones and trendy titles for our reports to make them a bit more sexy. And we've moved from this very standard format to working across many more surgical specialties and gradually focusing down increasingly on topics. But even within that, there were still a lot of common themes, dealing with elderly patients, who was operating when, and looking in some detail about subspecialty areas and their differences. One of the other enduring features of our work is the use of CPOD theatres. People don't talk about emergency theatres. For shorthand, they talk about CPOD theatres, because CPOD theatres are emergency theatres that are available 24 hours a day and staffed. And it's quite a mouthful to say that, but actually everybody now, even if they don't know what CPOD is, refers to them as CPOD theatres. There was also a recognition in many of our reports about the difficulties of operating out of hours because there wasn't enough access to theatres during reasonable working hours. And we frequently saw examples of very junior surgeons operating very late at night when they were tired, and there was lack of supervision, lack of communication with the consultants. And indeed, there was often, unfortunately, a failure to recognise the futility of surgery in many of our earlier reports. One of the things I've always liked about our reports, I say it myself, is using stories to paint a picture, because these mean something. If you've got the attention span of the average surgeon or anaesthetist, you want to get a message in a nice digestible form. This is the sort of thing you can read in between cases or while you're doing your anaesthetic. Just a few examples of some of the stories that we learned. So, elderly patient, previous gastric surgery for carcinoma, admitted with abdominal pain. An SHO, that's a Foundation 2 in modern parlance, immediately took to theatre and removed a normal appendix. But of course she was found to have carcinomatosis because they hadn't done any investigations beforehand, and later died of a PE, totally unnecessary operation. Moving forward a little bit to WOW 1, so that's who operates 1, the first one we did. Here's a case that has a familiar ring to me, 30 hours wait to explore a complex hand wound, and eventually taken to theatre by an SHO at 1 o'clock in the morning. And the reporter commented upon that lack of access to theatres. And I can remember this myself as a plastics SHO the first night I was on call, being told to take a spaghetti wrist with all the tendons slashed and the median nerve slashed. As an SHO, never done it before, never seen it before. I was told to get the book out the operating surgeon's room and given a bit of advice over the phone by the consultant. That was the way it was. And that didn't really start to be recognised until we started talking about that in public and putting it into reports. Everybody knew it was going on, but nobody said it. But we started to say it through NCPOT. Here's another one, 62-year-old ASA3. This is now from Functioning as a Team, a 2002 report. So the SHO in surgery recognised there was something not quite right about the ECG, didn't quite understand it, so he went to the anaesthetist and asked him, the registrar in anaesthetics, also recognised it wasn't quite right, but quickly looked at an old ECG, said it hasn't changed. But what he'd failed to recognise is that in between the one he'd looked at, the patient had had a coronary artery bypass graft. So actually that was a highly significant ECG, and needless to say, the patient succumbed afterwards. They didn't think of going to a cardiologist or even a physician to actually check it out. Moving forward, 2004 onwards, we changed our name, as I alluded to, and in changing our name covered a much wider remit across both surgery and other branches of medicine, and indeed even dipping our toe into out-of-hospital care. Much greater focus on topical issues, a more democratic process now for deciding what we were going to look at, using our steering group to assess topics which were submitted in by a whole variety of individuals, so much more stakeholder involvement than we had previously had. And we started to go into areas looking at new and innovative practices, so like bariatric surgery, for example, and looking at some of the slightly less mainstream stuff like cosmetic surgery, which has been highly topical. Just a couple more case studies for you, because I say I love the studies. So here is one from the report on bariatric surgery in 2012, too lean a service. Once again, you've got a high BMI patient, clear indications of mental health issues in the past, but no evidence whatsoever of liaison with the psychologist before surgery. So do a simple operation, you get the outcome that you expect from that, and accept that. Of course, if you look at this, at 6 months this patient had dropped from a BMI of 41 down to weighing just 44 kilos. And then he had to be admitted for intravenous feeding. So, highly successful operation, you might say, but a really terrible and very dangerous outcome for a patient due to a lack of recognition of the need for psychological input. And even more recently, and we're going to talk a little bit more about On the Right Track later on. On the Right Track, interesting because it was one of those studies that was actually triggered to some extent by repeated findings in the National Reporting and Learning Service data that patients were continuing to die after tracheostomy. And here you've got another obese patient, a feature of our modern society, which is becoming an increasing problem for all branches of medicine and surgery. And you've got an intensivist here performing a fairly routine and common procedure on the unit, but not recognising that needs to be adapted to the individual circumstances of the patient. So if you use a standard tube in somebody who has got a very long neck, then it's not going to work very well, and it's going to become displaced, and that's what happened here. And the patient got a tension pneumothorax due to the misplaced tube. We're often asked in NCPOD to define what our impact has been. It's difficult. It's always difficult, even in level 1 studies to draw and associate a causal relationship between what you do and the output. But we've got quite a lot of evidence, albeit circumstantial, of the impact of the inquiry. We've had many national reviews, many departments, and you'll see some of the examples of it out in the Platt room if you go and see some of the posters. Use our audit tools, which we produce in conjunction with each report to help local units see how they're doing against our recommendations. We produce guidelines. We've sometimes had national patient safety alerts through the MPSA, as we did with intravenous sedation, where people were just giving in bolus days-a-man. And putting people to sleep inadvertently. For national audits, we sometimes had, and quite often had, the national czars, the national clinical directors, taking elements of our report and building them into national policy, be that trauma, renal or cancer care. Finally, I just want to draw your attention to a really nice little tool that we have freely available. You can download it through onto your mobile phone. It's called the SORT Risk Adjustment Tool. Very, very simple indeed. And if you want to sit in the clinic and give a pretty accurate estimate of the risk for an individual patient, personalised for them, it takes about 6 clicks of a button, and it will give you a pretty reasonable risk of any procedure, of any specialty, with all of these parameters, ASA and so forth. So I would commend that to you. Please go and have a look at it during the break. Just download it onto your iPhone or other device. And finally, as I said, many of our themes are repeated, but many of them are as relevant today as they were back in 1987 when the first report came out. And Marissa Mason, our current chief executive, led the production of this really nice document. I think it synthesises all of our recommendations that are current. It's going to be a dynamic document which will be refreshed as new things come out of our newer reports. It's got lots of stories in there, lots of little case reports to help you understand the recommendations. So it's anything but a dry document, and I hope you've all got one of those in your pack. It's dead thin, so you can read it on the way home on the train. It's a lovely little document, and I commend it to you. That's all I've got to say.